Hi, everyone. Welcome back to Misconceptions. I have an exciting conversation up ahead today. I had the opportunity to meet Dr. Herman at a Chemed conference. Some of you may be familiar with that. Some of you may have never heard about it before. It's a Jewish medical ethics conference that I have the privilege of attending for the last several years. And Dr. Herman presented a conversation about BRCA, the BRCA gene, and I immediately followed up afterwards and said, I need to I need to bring this information to my community. So Dr. Herman, thank you for saying yes and agreeing to be here with me.
A pleasure. It's like I said, it's great to be here Erev Yontif, like right before the holiday. Nothing better to do than staying out of my wife's way.
There you go. There you go. So before we get into the conversation about the BRCA genes, I'd like you to tell us a little bit about who you are professionally.
Well, I'm an OBGYN. I just actually got my statistics because the hospital provides them, and I delivered 380 babies last year.
Amazing.
I have been doing that since 1992, approximately, and I think that I approximately delivered 12 to 13,000 babies. This past Thursday, I was had the good fortune of delivering twins for a girl that I delivered 25 years ago.
Oh,
And
that's
it's the
amazing.
first time. There's
Wow.
always something new that's going on, and it's really
That's
exciting.
fabulous.
Great that after 30 plus years, it's still exciting to go to work, and it
I,
is.
I love that. And where do you live? Where are you located?
I live in the Five Towns. My family moved into this area in 1960. So we're really one of the OGs, the originals, and I've been here ever since. And I practice in New Hyde Park. We have a little office in Hewlett, and I deliver babies in NYU, Long Island. Um,
Okay.
why are we talking about BRCA then if I deliver babies for a living? Well,
Yes.
as things turn out, God hands you things. And on the birth of my son 20 plus years ago, I had the opportunity to do his bris. Not many fathers get to do their children's bris, but I do the circumcisions professionally. So I asked my mom, could I do his bris? And he says, you're like the only one that I'll allow to because you actually know how to do this. So I did his bris, and then a few of my patients asked me, could I do their kids' bris? And I'm talking about my patients who are unaffiliated, not very religious, not connected. And I called my Moel and he said, well, go ahead and just, do them. So originally they came to the office and we would get whoever we could get together and we did these brisim for people who might go without it. Um, uh, a patient of mine, a New York City police officer and his wife had a little baby boy that I delivered. They live in Old Bethpage on Long Island and asked me, and I went to their house and I did their bris. And after I was done, this is 15 to 20 years ago now, the grandmother, the mother's mother, approached me near the front door and said, I took a breast cancer test and I'm positive. Would you take care of me? And I said, absolutely. But I really didn't know what she was talking about. So she went home and made an appointment. I went home and read the book and knew my job because she was BRCA positive was to take out her fallopian tubes and her ovaries. And I arranged that in the hospital. In fact, that's what I did. And a couple of days later, the pathologist called me and said, you saved her life. She has very early ovarian cancer. And now 20 years later or so, she's alive and well. And we've become very close, and she knows she's patient number one. I totally got freaked out by hearing this. And I went to speak to my colleagues, and they hardly knew what I was talking about, going back 15 years.
Right. So
Yeah,
before we continue, let's start with understanding some of the genetic prevalence of BRCA for those of us who who are completely naive to what is BRCA. I think that
sure.
I definitely have some knowledge coming from, I don't know, maybe just being involved in the women's health world the last 20 to 25 years. It was always a familiar term for me about being BRCA positive or being BRCA negative, understanding that from like the prevalence in the Ashkenazic Jewish bloodline. But it was also something that was like, well, if you don't have a mother or a sister or a grandmother, you don't have to think about it.
Okay,
So let's
which is totally not true, as you know.
exactly,
Okay, so
exactly.
let's go back.
Start with the science.
One of my favorite things is I finally figured out that high school was worth it.
Do share
Why?
because I have not figured out the Pythagorean theorem yet.
But we do know from high school what a dominant gene is and what a recessive gene is. And it's, the Punnett square, the recessive genes, big T, little t, big T, little t. But we must keep in mind that what we're talking about, the BRCA genes, are dominant genes. So if you have a broken gene, remember you get one from your mother, one from your father. If you get a broken BRCA gene, that's the way I like to refer to it, then you have this. As opposed to, like we know, Daria Sharm talks mostly about recessive genes, where you have to get a gene from your mother and an abnormal gene from your father, and then you have a chance of having a child with that. No, if you have an abnormal gene for BRCA, you have BRCA. Now, what is BRCA, by the way?
Let me just clarify one comment, that one wording that you're saying.
Sure.
Does everyone have the BRCA gene, and that some have an abnormal and some have a normal? Is that what you're saying?
That is exactly what I'm saying.
Okay.
We all have these gene sequences. And just to explain it to you, like I like to do, I have a zipper. My zipper works. That's DNA. But no matter where, if this zipper is broken, at the top, in the middle, or the bottom, once we're missing something or have an extra piece, the zipper doesn't work anymore. And that's how these genes in general work. So we have BRCA genes, and they help us avoid cancer. And if it's broken anywhere along the line, we lose the ability to fight off, let's say, breast cancer and ovarian cancer. This is hereditary breast and ovarian cancer syndrome. And these genes, if they work properly, great, which is most of us. But when they don't work properly, our chances of getting breast cancer and our chances of getting ovarian cancer are greatly improved, or not improved, greatly increased. Okay. I'll give you little numbers. I hate numbers, but I'm going to give you some numbers. The average person's chance of getting breast cancer in a life is what?
1 in 8.
Is 12.5%.
Okay.
The average person. What happens if someone's mother has breast cancer? What is, for all daughters of mothers who have breast cancer, what is their number?
That I don't know.
Okay, so if I ask people to guess, they generally guess 50%, 50-50, which is wrong.
Yeah.
Okay, it's 20%. So background is 12.5. Daughters of mothers with breast cancer is 20. And if you have an abnormal BRCA gene, a broken BRCA gene, that number is 50 to 70%. Low risk, high risk, really high risk. Okay. Thank God most people, when we detect breast cancer, do well. We know that it's not everybody, but with today's detection, and if people go for mammographies and they're aware, we're doing pretty good at taking care of them.
Okay.
Now let's turn to ovarian cancer, right? What is the chance of getting ovarian cancer? Again, let's start with this idea. If you go to school with 100 girls, 12.5 of them are going to get breast cancer by the time they grow old. And 1 in 70, or 1.3 of them, are going to get ovarian cancer. But ovarian cancer is very different than breast cancer. Why? What happens to someone who gets ovarian cancer? 75% of them die from their disease.
I mean, a lot of it is a detection issue that it's like a silent killer. Is that how you're explaining it?
Okay, so I explain it slightly different. I hate that terminology. It's become like too common now.
Okay.
What happens with breast cancer is we could find it early and it goes linearly, right? You could find it at the what they, a precancer state or stage 0 cancer as a DCIS, and then you could find it as stage 1, and you could find it as stage 2, and it spreads. It's 3 and 4, and so on. So there's a linear growth of breast cancer. What happens with ovarian cancer, I tell you, it's like a bomb blowing up inside your belly. 1 second it's not there, and the next second it could be found all over. Okay. So there's $1 billion race to do early detection of ovarian cancer, but it hasn't worked. And it's being studied all around the world, multiple institutions, and whatever they came up with sonograms, with blood tests, putting the sonogram and blood test together and doing it very often, we really haven't made any strides in the early detection of ovarian cancer, because it's like a bomb. It's just boom, it's there. And it's sad because we've had patients who go for an ultrasound. I'm thinking about someone in particular, totally normal. And 4 months later, it's all over the place. And It's just the saddest thing. You can't see anything. Wow, it's just so sad. You could just cry. And you know what's going to happen to her, and you just cry.
Yeah.
So 2 very different cancers, but hooked together with these BRCA genes. Okay. So now I contend that BRCA is not a test for the patient. It's a test for me so I could take care of the patient. So the average person who shows up in my office at 20 years old, they go, when should I go for a mammography? And I say, hey, the recommendation is 40 years old if there's no other reason to do it. If you're the average person with the average risk, that 12.5%, and it starts later in life, you don't have to test a 5-year-old. The chance of getting breast cancer is zero. But at 40 years old, it starts accelerating. So we start doing mammography at 40. Okay. Because why did we get to that? We got to that because that was our risk analysis. We analyzed your risk to be 12.5%. Right. But what happens if we analyze your risk and instead of 12.5, it's 50 to 70%?
Right.
Get those numbers, 50 to 70. And not only that, those breast cancers can start at 25 years old. Well, then we're not going to wait for 40 years old to start our mammographies. We're going to start doing surveillance at 25 years old, right? So we change the age and we change what we're going to do. Okay. So I don't know, I tell my patients, you look very nice, but I don't know how to take care of you. I need this blood test because it is a blood test. People say, oh, it's just a simple blood test. Yeah, the blood test is simple. It's the implications that are very
Sure.
important, right? I could go ahead and take care of you because I have the knowledge of what your risk is. If I don't know what your risk is, then what am I supposed to do for you? Hey, get a mammography at 40, but something bad happens to you at 27 or 37 because we weren't looking for it.
Mhm.
So what we do is we do risk evaluation, and then because of that, we could go ahead and do risk reduction. But we can't figure out what to do until we know that.
Are you assessing for risk? Is your risk evaluation purely about family history, or is there now I heard from you a little bit
Huh?
different in that where a risk assessment is not just going to be based on family history. So how do you define for your practice, how do you do risk assessment?
Okay. So that's part of our risk assessment because we assessed, hey, your mother had breast cancer and your grandmother had breast cancer. Hey, we need to look into whether you carry this gene. And then from that, we figure it out and we again assign you a risk score, 12.5 or 50 to 70. Okay. But we also look at personal risk. Have you had breast biopsies? What did those breast biopsies shown us? How old were you when you got your first period? There's a lot of factors that go into figuring out and doing a proper risk assessment. And online, you could find these risk assessment tools that are available for everybody,
Hmm.
right? There's a model called IBIS.
Okay.
Okay. And you could look for IBIS, breast cancer model, and just follow the instructions and follow the questions, and they'll tell you what your chances of getting breast cancer in the next 10 years and in lifetime. Okay. And with that knowledge, you could get different services. So a lot of this is assigning risk, and based on risk, you could get services. I say it's like your kids in school. You can't get services until you get a label.
Right.
So now you have a label, and your insurance will pay for this. Okay, we'll pay for your treatments, we'll pay for your evaluation if you have the proper label. So you can't just say, hey, I want to get an MRI of my breast because it sounds nice for me to get it. My friend got one. But if you're labeled, then you can. And there are different labels you could get. You could get a risk number like we talked about. It turns out that if you're greater than a 20 to 25% lifetime risk to get breast cancer, then you're entitled to get an annual breast MRI.
Right.
Okay.
Right. And insurance has to pay for that.
Correct. And
Okay.
if not, it won't pay for it.
Right.
No, it's that
Right.
simple. So if we have the information, we could do that. Okay. That's on a personal level. You come for a BRCA test for some reason. We could talk about the reasons in a minute. And you find out your risk. Let's say you're BRCA positive and you're at very high risk for breast and ovarian cancer. Now your insurance will pay for what you need. Now, obviously, it doesn't apply to every person in every case, but for the average person who has average insurance, that insurance now will cover evaluation and treatment of your risk.
Okay. And so one of the things I'm thinking about is introduce to us then the concept of the Ashkenazi risk.
So as we talked about already, everybody has BRCA genes, right? And when they function properly, they protect you from breast and ovarian cancer. And when they don't, when they're broken, they don't. Well, it turns out that on average around the world, every community has it, every ethnicity, every country, there is none that does not. The chance of having an abnormal gene is about 1 in 500 people outside of the Ashkenazi community.
Okay.
But in the Ashkenazi community, it's about 1 in 40 people. Okay, and this has been shown, this is borne out. They did a study in Yerushalayim a few years back where they took Ashkenazi families who had no cancer in it and they tested them. And guess what they found? 1 in 40 of them had it. And then eventually the cancer started showing up. Okay, so listen to this, just to wrap your head around it. In a non-Ashkenazi family, you need 2 people in your family to have cancer, a breast cancer or ovarian cancer, to qualify for testing, meaning insurance will pay for it, right? Okay. In an Ashkenazi family, it's equivalent to being born with an aunt with ovarian cancer. Okay. So when we are born, I'm Ashkenaz, when we are born, our history is equivalent to, I have an aunt with ovarian cancer. And now if there's any breast cancer in the family or any other ovarian cancer in the family, I'm entitled by insurance. I qualify for testing and I can get tested.
Okay? Wow. Wow.
So outside, you need 2 things. For us, we need anything. And we're talking about a father, mother, grandmother, grandfather, sister, brother, child.
Okay.
So first and second degree relatives, and you can count on your fingers. So mother,
right.
First degree, mother, grandmother, mother, grandfather, and we work from there.
Tell me, so are there any other populations in the world that have a higher risk or rate of a BRCA positivity, or only Ashkenazi Judaism?
There are little variations, but we're number 1, baby. We're number 1.
Oh, lucky us.
We just lead the league. There's nobody close to us.
And that's just an issue of like genetic bottlenecking. Is that just like,
well, if you think like we were in the shtetls, and this came up, and we stayed to ourselves, when we didn't have a lot of genetic variation, and then we were killed in pogroms, and we just funneled together and funneled together and funneled together, and now that we're growing, we're passing these genes along.
Okay. And so I do want to address the issue of men, because right now we're just speaking about BRCA positivity or BRCA positive females and breast and ovarian cancer. Talk to me a bit about the risk for men. Why would we ever test a male?
Okay, so there's a couple of reasons, and it would be a much longer conversation. There are 2 BRCA genes that today we're talking about. Now we've learned about a whole bunch of other genes that have an influence on this whole cancer story. We have genes that do a similar thing for colon cancer. We have to do for prostate cancer, for pancreatic cancer. And now instead of BRCA testing, we talk about hereditary cancer risk assessment, where we could get tested for all of these known genes in one basket. But for today, we're just talking about BRCA. Okay, there's BRCA1 and BRCA2, which were discovered, I believe it was 1994 or 1995, or patented in those years. There was a gigantic race to sequence these genes as the sequencers got better and bigger and stronger, and they finally isolated these genes and identified them. But they're different. BRCA1 is different than BRCA2, right? And BRCA1 generally, on average, carries a 70% chance of breast cancer and a 40% chance of ovarian cancer, while BRCA2 is 50 and 19. So I call it 15 and 20, 50 and 20. So 70, 40, 50 and 20. Okay, but if we look at BRCA2, it also increases the risk of other cancers. For example, male breast cancer. 2,000 men a year get breast cancer in the United States, 220,000 women. Men do get breast cancer. Okay, so if you are BRCA2 positive male, you're at an increased risk to get breast cancer. And some of them, they do breast exams, they go for mammographies, or they'll have breast tissue removed, depending on what the situation is. Additionally, there's a slight increase for men and women of pancreatic cancer. for melanoma, and for men, prostate cancer. Now, prostate cancer is so common. They said if you live long enough, every man is going to get prostate cancer. But if you see a very young person with prostate cancer and an aggressive prostate cancer, it makes you start thinking of
Like
possibly, hey,
genetics.
should we be looking at the genetics of this?
Hmm.
Also, and this was just a story, it increases the chance of ocular melanoma. Now, in my career, I didn't even know what ocular melanoma was. I'm an OBGYN. But one night I was giving a lecture. And at the end of the lecture, a doctor came over to me and said, my roommate from college got ocular melanoma and he passed away. And that was like years and years and years. I said, maybe if you're friendly with them, you should go back. It's so rare, and suggest that they get tested. So one of the things is it's associated with other cancers and male cancers. And now we're learning more and more about these genes, and BRCA1 might be associated with additional cancers, but BRCA2 for
The main
certain.
one.
Okay. Now I'm going to give you a different scenario. Somebody comes to my office, just delivered their baby, they're 27 years old, and they said, my father's mother, Ashkenaz, had ovarian cancer. I just found out. My family never told me. I was a little girl. They never told me, but I just found out. I go, was somebody in the family BRCA tested? And they go, what do you mean? I go, well, in an Ashkenazi family, if you have any cancer, breast or ovarian, we should assess the family. Because, well, my grandmother's not alive. I go, how about your father? And they look at me, they go, like, my father? I thought this is breast and ovarian cancer. I go, let me ask you a question. How many kids are you guys? And they said, Kanai Nahara, we're 9 children in our family. So if I test the father and the father's negative, then I don't have to go ahead and test all 9 children. And I go, by the way, how many siblings does your father have?
Hmm.
And they say to me, well, they have 7, siblings. So we always try to test a person at the top, because now we have 7 of the uncles and aunts to test. They each have 6 or 7 kids, right? So if I go ahead and I just test this patient in front of me, I just missed 75 people.
Sure.
Who potentially I could save their lives or be a part of saving their lives, because we just do what we're supposed to do.
Right.
And 120 years, when I reach 120, they'll still be taking care of patients from this blood test and improving their lives, extending their lives, and having them there for their family.
Okay, so I want to do this pushback thing where
Sure.
I know what's been talked about, kind of socially and socioculturally about when people should be tested and what are the risks of testing people in terms of stigma and knowledge about how does it feel to somebody to be like, I'm a carrier of something that's really scary that puts me in a really high risk. So can we break it down in a couple different ways? I'd like
Right.
to talk about stigma. Okay, let's start there. Go for that.
So that I would say is about, I don't know, a 7 to 17 hour conversation.
I know it. I know.
Okay.
I know. But I want to hear how you respond when somebody,
So
and I want, let me just give me 1 second, because I have listeners in my community, in my podcast community, who are not religious Jews and who maybe not really be aware of the concern. But just to set it up, is that we tend to intramarry, meaning we're set up, we're connected. We actually do a lot of research into the person that our children are going to be marrying. And so very often there's a question of disclosure. If I know that I am BRCA positive, does that mean that I need or am obligated to disclose that to a potential mate of my child or my own potential mate? And that's where the question of, do I want to be saddled with this information? It's always been kind of part of the wording, right? And I see you wiggle, I see the discomfort there. I'm
yeah.
repeating the conversation, right? I'm repeating what I hear out there. Let's start with stigma being, how does when somebody comes to you and says, Doc, I don't think I should do it because I haven't married off all my children, or I'm not married yet. What do you respond?
Okay. So we face this all day long,
Of course you do.
and it's a real concern. And now, as I like to do, I'm going to get myself in trouble. Is it a valid concern?
Go
Okay.
for it.
So let me tell you a few things. I looked at every test that I do in my office, and my patients don't want any of the testing that I do. Who comes to the office and wants a pap smear? Actually, I always joke, if you like a pap smear, you're not allowed to come back again to my I'm sorry. If you
That has
like
got to be
that,
an
you
OBGYN
know,
joke on
do
steroids.
not come back here. Who wants to go for a mammography? Who wants a breast exam? Who wants a colonoscopy? And my little joke was, there's only one test that I found in my office that half the people want to do, and that's a pregnancy test. Half of them are
Mhm.
afraid of it, half of them really want it. Okay. But with that said, nobody wants this test. Who would want this test done? Okay. But you come to me so I could evaluate your risk. You get a PAP to find out what your risk is of cervical cancer. You get a mammography to find out what your risk is of breast cancer. You get a colonoscopy to figure out what your risk is of colon cancer. My job is to take care of you. Okay. So that's one concept. Patients don't want any of the testing I do in my office, but they also rely on me to do the right thing by them and take care of them. And as I alluded to, I need this information so I could take care of you. You could either say, guess at taking care of me, and if you get it wrong, that's fine, or do the best possible job. So it's not a test for you, it's a test for me. Okay. Now, with this conversation, we do get a little bit of a break because the breast cancers start at 25 years old. The ovarian cancers start to close to or after 40 years old. So in general, we don't need to test anybody before 25. There are
Okay.
some exceptions, and I'll tell you an exception. If somebody's mother got breast cancer at, at 30, you might test them at 20. But in general, the average person, it happened a little bit later, we're starting at 25. So hopefully they're married by then, and so on. But what happens if someone's not? Okay, so I'm going to give you perspective and then I'll talk about a couple other things. Should I let you die? No, I can't do that. I can't just let you get sick. When I know you have your father is BRCA positive, you have a 50-50 chance. I need to take care of you,
Mm.
and it's hard news. It's hard news, but we need to do what we need to do. Okay. It's very interesting that when I have families who are BRCA positive, that the sisters who are negative feel worse than the sisters that are positive.
Interesting. Hmm.
They say, "Why was I lucky and I didn't get this?" And they
Like a
feel
survivor's guilt. Hmm.
yeah.
Hmm. Hmm. Hmm.
Okay, but I'm going to give you another little thing to think about. If I know someone is BRCA positive and I take care of them properly, their chance of getting breast cancer is less than someone who's BRCA negative. Their chances of ovarian cancer are less than somebody who's BRCA negative if we take care of them properly. But obviously, we first have to know that they have it. But once they have it, what we have really works.
Hmm.
So eventually, their chance of getting or not doing well with these cancers are less than the average population. So we could get the chance down to almost zero, never to zero, but close to zero, less than the regular person's chance.
Talk to me about the prophylactic,
Okay.
kind of options and how that works.
Okay, we're going to, but I want to finish off
Go
this
for
first
it.
presentation. So many years ago, when I was sitting at my dining room table and I had a family that came to me, a husband and wife, and they say, "What do the rabbis say? What do the rabbanim say?" So all the way back, Rav Elyashiv, alive and well at that point, you know, um, I contacted him and I spoke to his gabbai because I wanted to speak in English. And I got on the phone and I'm all ready for this long conversation. And I say, "What do I need to tell you about BRCA?" And he goes, "We know everything." Right? And then they asked me, "Who are you testing? Are you testing appropriate people?" I said, "Yes, I'm testing appropriate people." "Great. That's what we want you to do." I go, "Could I take out and do these surgeries, the appropriate, He goes, they said, "Absolutely." I go, "The patient's not sick. I just want to be clear. We're avoiding illness. Can I do this?" And they go, "Yes, it's absolutely, absolutely fine to do." And I was off the phone in 7 minutes. I thought it was going to be a 2-minute conversation.
Right.
Okay.
Right.
Okay. Then we go back to the conversation is what should be revealed when somebody is going out. Okay. I've spoken to numerous different rabbinical sources from different communities, and I'm sure there are dissenters, but this is not something that needs to be volunteered. And I alluded to the reasons why. One is the person is not sick. They don't have an illness. You might have to say that their mother had breast cancer and their grandmother had breast cancer and their aunt had breast cancer, but you don't have to say that they're carrying a BRCA gene. And secondly, is if we know they're carrying the BRCA gene, they are less likely to get ovarian cancer than someone who doesn't. And they're less likely to have a serious breast cancer than somebody who doesn't. They're in
Yeah,
better shape
I
than the
love
people
that.
that have. Okay.
Yeah.
With that said, we understand it. We created a society now that if you have a genetic something, there's something wrong with you. Meanwhile, if we go back to Gemara, in the history of the Gemara, there's seven perfect people. It's not me, you get over it. Take care of yourself and take care of your children.
Hmm. Hmm.
Okay. You show me the perfect person. Okay. I'm hoping somewhere in our world it does exist, but it doesn't. And again, I talk about the average person in the average family and who's doing everything that they're supposed to be.
Right. Right.
So I am told that if someone asks you directly, you're supposed to answer that question. But it's so hard for me to believe that a mother would let their daughter get sick and not
Hmm.
test them versus
Right.
getting.
I hear you. I
It's
hear
just,
you.
and I get the angst. I
I
get the,
hear it. I see it. Right.
I'm there.
Right. I
I'm
know.
there. I get it.
I
But
absolutely see it.
but at the end of the day, who should let their
Yeah.
child get sick?
And
You
so
know?
is your recommendation as an OBGYN, based on everything, I think I know the answer, but I want to hear it from
Yeah.
you, based on your recommendation by the age of 25, if we have no clear indications of personal risk other than being an Ashkenazic Jew, you would still suggest by age 25, get BRCA tested so your doctor can know how to take care of you properly.
No.
No. Okay, correct
No.
me.
You need to be Ashkenazi, again, equivalent to
Ashkenaz, Ashkenaz, yeah.
Ashkenaz, which is equivalent to you have an aunt with ovarian cancer.
Right.
That still doesn't qualify you for testing. You
Okay.
need some other cancer in your family
Okay.
to get tested. That is the recommendations, and those have always been the recommendations.
And would you say any kind of cancer in your family?
No, we're talking about breast,
Just the
ovarian.
breast and ovarian cancer.
You could keep an eye on the pancreatic
I was gonna
cancer. You
say,
could keep an
right.
eye on. Okay, but for our purposes, is cancers
Okay.
that are related to BRCA. So
BRCA.
if you need one of those, because you're born already with one.
Can I ask
You're
you something?
born,
Would you suggest that somebody private pay for it? Your insurance is not going to cover it, but it's not a very expensive test. It's like $250. Would you suggest go for it because you're Ashkenaz, period? Go for it?
okay, so you're asking me really tough questions over here. The national recommendation is not. However, Mary Claire King, who's probably the most famous geneticist and is the discoverer of BRCA1, she suggests that every woman get tested by 30 years old. It's
Yeah.
not been accepted nationally. That was numerous years ago. It hasn't been adopted by anybody. There have been pilot projects where Ashkenazim, if you adjust to Ashkenazi, they had funds and they just paid for it. But I always say, we're so far behind right now. Why don't we take the low-hanging fruit, the families that have this in them,
Got
before
it.
we start pushing hey,
Got
I
it.
don't have anything in my family. Could you go ahead and test me?
Right.
If
Right.
you came to me and said, I really, really want to do this because my best friend is BRCA positive, okay, spend your $259 and get it. But I can't be out there today advocating it. I'm hoping the test will drop down to $50. And then at 25 years old, it'll be a national thing that everybody gets tested, because we're certainly a number of studies showed that like this is not a bad idea and probably cost-wise is worth it.
Hmm. It's
Okay.
interesting, a couple of things I want to just point out. One is that, as people who are coming from families from the Holocaust, like there really is limited family, history just in
Yes.
general. So we just want to acknowledge that while we're really talking about first degree relatives, and in 2025, that's several degrees
Right.
prior, but we do
So
have
we've
some
dealt with
truncation.
that.
Yeah, we have some
Also,
truncation of
adoption.
the knowledge. Right, exactly.
Adoption. I'm adopted. I don't have a
Yeah.
family. What
And
should I
I'm
do?
and I'm going to say we have donor conception. We
Right.
absolutely are seeing donor conception in the
So
religious world on the down low, but it's happening. That also you don't really know your BRCA risk if you don't have a clear genetic, and that's not typically going to be tested for by the donor.
yeah. If you want to learn a little bit more about donor situations, I did a podcast or numerous podcasts with Rabbi Siegelman from PUA. great organization.
Sure.
They're, they're on YouTube. You could just go look for them. And we
Yep.
go through all these donor situations, and so on.
Yeah,
And it's highly, highly interesting.
they are. Yeah.
So now we get to our patient. If we're done with that, we can move on.
We're good with that. I do want to, one thing I just want to drop here is that everybody should be aware, in case you're not, that people who are getting tested by Dvora, as you mentioned, that is an organization that tests for, typically is being used for pre-marriage testing and like screening that does not include any kind of BRCA testing at all. So they are actually up to like 54 tests right now from the last time I checked the website. But none of those are inclusive of BRCA. So don't think, because I've had somebody tell me this, oh yeah, I did Dvora, so I'm covered if I was okay on, like, it is not related to BRCA at all. So just wanted to make sure that the audience is aware of that. Go ahead.
And we love them. And I've asked on numerous occasions, could you please tell patients that you are not medically tested?
Right.
Okay, that what they're rabbanim. And let me tell you something, I never met more knowledgeable people in my life than Dvora. It's crazy how knowledgeable they are. But they have a mandate and a task, which is different than my task and my
Correct.
mandate.
Yes.
And we talk about it all the time, and that's where they're up to. And you should do it, take advantage of it.
And
They're
be knowledgeable about what you are testing for
and
and what you are
what
not testing for.
That's correct. Okay, so now we're talking about a woman who's gets tested and she's BRCA1 positive, and we figured out that her risk in life, instead of 12.5%, she's a 70% chance during her life, not today, but during her life, to get breast cancer. And instead of a 1.3% chance of getting ovarian cancer, it's now 40% chance in her life of getting that. And your question was, what do we do about that? Okay, and you mentioned prophylactic surgeries. So those are words that you're never going to hear out of my mouth, because I'm going to change, and hopefully change how I'm on a mission to change
I
how we
love it.
talk
Tell
about
me
it.
more. Tell me more.
Prophylactic is not so understandable by everybody, but risk-reducing surgery is. If we do surgery, and we'll go to each one of them, we could reduce the risk of getting breast cancer. We could reduce the risk of getting ovarian cancer. And everybody understands what we're talking about. And just because we haven't mentioned it, when we say ovarian cancer, that includes as a unit fallopian tube cancer, right? It's ovarian, and they get taken out as a unit, because 20% of what we talked about was ovarian cancer really starts in the fallopian tubes. Okay. So I had a story going all the way back. I told you about my first patient, right? About 14 months after that, I had a 63-year-old Jewish woman who came to me with a diagnosis of breast cancer. And I said, where is your BRCA test? She says, what are you talking about? I go, your breast surgeon and your plastic surgeon, your oncologist never suggested that you get this? And she goes, no, I don't even know what that is. So I explained it to her, and I took her blood, and of course it came back positive. If it didn't, I don't have a story to tell you. So again, I knew my job was to take out her fallopian tubes and her ovaries. So I took her to the OR, I took them out, and a week later, again, the pathologist called me and said, you saved her life. She has stage 1 fallopian tube cancer. This was before that we really knew the association. And it's only through doing many people that we figured out that 20% of what we thought was ovarian actually starts in the fallopian tube. Okay. With that said, let's go back to our patient. 70% risk of getting breast cancer at some point in our life. She's older than 25 years old. What do we do for her? Okay, 2 basic tracks. There's more stuff that we could do, but we're going to leave it at the basics. We could follow the road where we're just going to watch her. Remember, we talked about breast cancer, starts at a low stage and, increases as time goes by. And if we watch them really close, we're not going to reduce the chance of breast cancer, but we'll find it really early, and we'll treat them, and they should be okay. So from 25 to 30 years old, we get an annual MRI, not covered if they're not BRCA positive. Right? And you need to know that if you look so closely with such great acuity, you're going to find different things that are not breast cancer. And it's very common. You should go in there knowing you're going to probably end up with a breast biopsy, or 1, 3, 5, or 7 of them over the years that you do this. It would not be, everybody would be worried that you have breast cancer, and even the tiniest thing, they're going to go ahead and biopsy. Okay. Starting at 30 years old, not only do you get a MRI each year, but on the 6 month interval, you end up getting a mammography as well. So it's, it's MRI, mammography, MRI, mammography, MRI. That is breast surveillance.
Okay.
Okay. We don't stop it from coming, but we find it so early that the patient will be okay. I support this. It works very well, and it is definitely statistically a good way to do that. And if that's what you would like to do personally, because this is a personal thing, we're going to get this done for you.
Okay, I pause for 1 second because one of the other docs on your panel, when I heard you speak, said something to me that was incredibly profound, which,
Okay.
and I just want to hear it from you,
Sure.
this perspective that there are breast cancers that look like cysts, but or just like benign nothings that you would normally not further test. However, if you are BRCA positive and you know you're BRCA positive, that you actually, those growths really need to be further tested because a significant percentage of them actually are cancerous. Can you just speak to that for a minute? Because I had never heard that before.
So I can't give you the statistics of it.
That's fine.
Okay. And we say a significant amount, one makes it significant.
Sure.
One life is significant. And I was sort of alluding to that by saying, like, anytime they see anything, even a little bit small, they're going to biopsy it. So I don't really talk about it as an MRI with a biopsy, but maybe we should, because you're going to end up getting biopsy. They're looking at the tiniest things and things that they normally wouldn't touch. And now they want to just make sure that you're okay because they want you to live for, many happy years.
Thank you.
So that's one track. The other track is risk reducing surgery. Okay. Again, a personal choice. So what we do today, and there are numerous ways to do this, and there are surgeons and plastic surgeons who specialize in these risk reducing mastectomies with breast reconstruction. And I never say risk reducing mastectomy, right, without the breast reconstruction, because if you don't have the breast reconstruction, a lot of people wouldn't be doing their mastectomy. When I started, they used to remove the nipple. Now, after experience, a lot of patients will leave their intact nipple. The skin is left. So they go in and they remove the breast tissue, leaving the skin and nipple behind. And then there are two general tracks to how they reconstruct it. One is they'll put in a breast implant. And two is they'll take fat from someplace else in your body, like your behind, like from your leg, like from your belly, and bring it up and make you a breast mound. It's not breast tissue, but they could shape it and make it look, very nice these days. And they work at again, they call it restoring. They want to restore, you to where you should be. Okay. So people go, that's crazy. Who would do something like that? Okay. Well, I've had patients who in high school watch their mother come home from school every day and see their mother languishing on the couch until their mother faded away and died when they were 17. And now they're BRCA positive and they say, I lived through this. I just can't do that again. I'll do what I want, what I need for me. So at first, and sometimes people are like aghast at even the suggestion, but when you put this personal situation for a person, they get to make that choice. I've had patients say, I want to breastfeed my first baby. Right after I've bonded with, I learned that is, then I've had patients say, I want to wait till my kids are out of the house. And I have patients who say, I just want to do surveillance and I'm happy with that. And it's a choice that should be made by the patient for the patient with whoever they include in their circle. And it's also a little bit hard when the nail salon lady is telling them, you need to have a mastectomy. You're crazy if you don't have one. And then they go to the dermatologist who says, you need to have that, but they really don't need to have that. Mm-hmm. They need to make a choice that's good for them, as opposed to a choice that's someone else is hoisting on them.
Yeah.
That's the breast cancer story. When it comes to ovarian cancer, we get a little bit of a break and it happens later on. So what is the recommendation? because remember, there's no real surveillance, to take out the fallopian tubes and the ovaries around the age of 40 when done childbearing. So sometimes you read these articles and it says, I didn't have children because I was BRCA positive. And I'm going, oh my God, who's giving them advice? This was never the recommendation. Newspapers want to sell articles, but that's just wrong.
Right.
Have as many kids as you want, and then one kid by accident after that. And then when it's time, take out your tubes and ovaries. We will replace those hormones until menopause and beyond, depending on what the situation is, to keep you young and healthy. Okay? Because your risk is 70%, is 40% to get over, and if you get it, there's not
It's
really
pretty much
turning back.
deadly. Is there any reason why we're not taking out the uterus at the same time? Is there a medical reason not to take out the uterus?
Yeah. Why didn't you take out the gallbladder and the appendix? Why didn't you ask me if we should take out the
It's all
gallbladder?
part of the same system. I mean,
Okay, but it's not. This is hereditary breast and ovarian cancer
okay.
syndrome. There are reasons to take it out. There are people who just say, I want it out, like you sort of was
Question like
suggesting.
why leave it in? Right.
Okay, the first time someone's ureter gets damaged in an operation that you really don't need to do, and now they have problems with the urinary system that they
Got
need
it.
multiple operations. It sounds
Just
nice.
there's no reason.
Okay, there are some reasons. For example, some patients, I've never had one who would like to take tamoxifen. That could have an adverse effect. So they will do that. Some patients want to take estrogen for hormone replacement and not estrogen and progesterone. And remember, today, you know how long these operations take?
Yeah.
I could take I could do a laparoscopy and remove the tubes and ovaries in 20 minutes. Okay, so I say it's between a half an hour and an hour, not going quickly, and the patient goes home 2 hours later if they feel rotten for, 3 days, and it takes 3 weeks until all the tenderness is gone, but also the menopausal at that point. And you got to
Right.
remember that. And that's harder to deal with than the recovery.
For sure.
Hysterectomy adds, in the regular average patient, it's 45 minutes, adds an hour and 15 minutes to the story. And the patient, might feel better. Listen, I want hormone replacement. I only want to take estrogen. Who needs periods anyway? Why do I have to worry about my uterus while you're there? Take it out. I'm already there. It's an hour and change more. Do it. And a lot of doctors now will do that routinely. I think they need to explain to the patients, a little bit more of why they're doing that. Oh, I'm
And
BRCA.
there's no risk of cervical cancer, increased risk of cervical cancer or uterine cancers with people who are BRCA positive.
That's correct.
Okay.
There was
And
one
and once
report.
you're removing the ovaries, they shouldn't be getting a period, right?
There was one report that said there was some rare uterine cancer that they found like 4 or 5 cases or something
Okay.
like that. And
Okay.
there was
Okay.
one article of everything
Right.
everywhere. But
Now,
no,
removal of the ovaries, they are removing your menstruation. Like there shouldn't be a period associated
well,
post-surgical.
the ovaries are what are the hormones are supplying the hormones and giving the messages to the uterus. And if the uterus is not given a message to make a period, to have a period, then it's not going to do that.
Right. Okay. So it really isn't an issue that I want to take out my uterus so I don't have any more periods. That's effectively going to happen anyways because you're removing the ovaries. Okay.
That's correct. But can't I
Okay.
get uterine cancer later in life? Okay, yeah, anybody could get that, but we don't take out everybody's uterus just because you could
Just
get
because of that.
cancer
Right.
later in life.
Okay. So I guess I would, in looking at our time, what did I not ask you that you want to make sure is very clear? And then I'm going to also ask you to identify some misconceptions that you want to make sure people know are misconceptions about BRCA.
So, so I've alluded to those already. A BRCA test is not a BRCA test for you. It's a BRCA test for me so I could take care of you. Taking a family history, again, is for me so I could evaluate what your risk is, and it goes through the whole pap smear, mammography, and so on. Those are not tests that you want. You don't want this test. You don't want any test, but I do that. You rely on me to take care of you. And that's really the way that I view this. Okay. Stigma is what we cause ourselves to have. And like I said, protect your children. You do anything, you'd run in front of a car to push your kid out of the way to get a blood test to save them. And this is real. This is real. I'm going to tell you a story and I cry. I cry over the story. A patient of mine who knew her mom, was BRCA positive, but said, I don't want to do this. I don't want to do that. And eventually got cancer that I felt in my heart we could have prevented.
Mm.
And now when I deliver grandchildren, that she's not seeing from here. I say, I wish you would be complaining how I made her menopausal and I caused her this and I caused her that and night flashes, hot flashes and this and that, but she'd be here to see the kids. And that one story has stuck with me and drives me and drives me and drives me to never let that happen again.
Mm, mm, mm,
And
mm.
so I don't think there are real misconceptions. It's
Okay.
just, you just have to know the story. Once you know the story and we choose the proper people, right, who should get tested, we understand why they should get tested, and we understand what we could do for them. We don't do tests
Right.
that we can't do anything about. This test, I talk about, I think I don't, again, I saved. I don't believe I saved. I was involved in the care of patients. I do pap smears every day. I think I save more people doing this than pap smears, for the
Mm,
last 50 years, especially
mhm.
in our patient population.
Right. Right.
So it's so hard when you hear in the community that someone had breast cancer and then they found out, oh, guess what? They're BRCA positive, but they had an aunt with breast cancer.
Right.
Like you never should have had breast cancer.
Right, right. I
So
mean, I've brought this
it's
up, by the way.
knowledge.
You should know that
Yeah.
it's knowledge is everything. I mean, I brought this up with a group of master level students,
Huh?
and a group of them had no idea what I was talking about. And the reason I brought this up in conversation was a maternal health class. But she said, one of my students said that her mother and her aunt and her grandmother all had breast cancer within a very young age diagnosis, and nobody had discussed this with her.
Right.
And I remember my heart pounding, thinking like, I can't believe I'm the teacher in a
Yeah.
class having this conversation with her and saying like, and I followed up with her like, did you call your OB? Did you talk tomorrow? You got to do this now, like to save your potential future.
We have stories like this that go on and on and on.
Yeah.
You know, when I used to teach doctors about this, I lectured across the United States 600 times or something like that. And every
Mm.
day, unofficial lectures, what are we doing now?
Right.
And so on, is I would go and speak to them in their office. And I said, forget about your patients. First, let's look at your family. Who's working in your office? I bet you someone working in your office right now has a history of breast cancer in the family or ovarian cancer. Let's start with them. Let's take care of your employees. Let's take care of, and you know something? In every single office,
Hmm.
I found somebody without a doubt.
Wow.
Okay. Yes, those were in the day before you knew the word BRCA.
Yeah.
I used to start teaching is BRCA, is a test we do to look for hereditary breast and ovarian. Okay, now, thank God, people have heard, those, and they'll actually come in and ask for it.
Right. Right.
Okay, we're up to that point, thank God, with education. But
Yeah.
we have to educate, keep our eyes open. I said, why should men come hear what I have to say? Because you asked me, because their next door neighbor or the person they sit in shul with, they hear that their wife had, and they should, again, suggest,
Absolutely.
that they do that.
Absolutely. I want to bring one comment out because I asked this for you after we spoke at the conference. I just wanted to address it for full transparency. If you do remember that we are a part of a national health record. And so that means that if you do this test, it is a part of your formal record. That means
Uh-huh.
if you go for disability, life insurance, things like that, that is going to be a part of your national kind of medical record. So while they cannot officially, my understanding is they cannot deny you life insurance, but it will be more expensive. And I liked your answer. You said to me, get your life insurance first and then get tested. Right.
But
Just
also,
can you address that a little bit?
we haven't really seen that happen. And I've been watching this for 15 years. How do I watch it? I listen to all the stories.
Yeah.
I have Google alerts, and I haven't heard a single story of this. And
Yeah.
let me remind you this. You don't get tested and you get breast cancer. Now it's going to happen to your insurance.
Exactly.
And
Exactly.
you have a chance of dying, and you're not going to be there for your children. So, type
In
of
the
thing.
larger picture of
In the
things,
larger picture, it
you have
doesn't
to
make
measure
sense.
this.
If you're
Hmm.
going to take that attitude, do not go for a mammography, do not get a pap smear, do not go for a colonoscopy, do not go to the doctor. Because if they don't know that you're ill, wow, your insurance will be less. Unfortunately, you'll be sick.
Got it. I
Okay.
appreciate that.
And then we also talked about, and if you get treatment for BRCA, you have a gripe against your insurance company because now your chance is less of getting breast cancer and ovarian cancer. They should give you a refund.
I hear
Okay,
you. I hear you.
because now that you're tested, your chance is less than everybody else.
Right,
So
right,
how can they
right,
charge you more when your risk is less?
right.
From what I understand, and I'm not 100%, they're not allowed to ask you about your genetics, and they're not allowed to make any decision based on your genetics. There's a national law called the GINA law. I don't know the ins and outs in it, but basically that's the
Yeah.
story. And now I've been watching this again for 15 years, and I haven't heard of a case ever.
Excellent. 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 This has been a fantastic conversation.
Right.
I am so grateful that
Want to
you're
do a
willing to
few
do
more
this.
hours? We could do
I
this.
would lie. I could. We could. It's too bad I
Yeah,
have to go somewhere else at four
yeah,
o'clock. But
yeah.
truly, thank you. Thank you for your time and for your passion. I will say, my husband and I, when we heard you speak, he was sitting next to me. We looked at each other. We said, we need to have this conversation. We actually are scheduled for a geneticist consult just to ask the questions. We are of age. It's not relevant to more children. And it's just like, why don't I just assess for my risks? And my husband felt the same way. Both of us were like, we're calling tomorrow. So you inspired us, and I felt inspired to bring this conversation to the community, and I know it will make a difference. So thank you so much.
I believe it. Good. Have a good Yantif.